Hello. 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 Good morning. Hello. గట్టిగా మాట్లాడాలి. షౌట్ చేసి చెప్తాం కదా. Hello, good morning. Hello.
మామూలు ఫేస్లో మాట్లాడు.
మామూలుగా మాట్లాడితేనే గట్టిగా వస్తుంది సార్. హలో, మైక్ టెస్టింగ్. హలో హలో.
సార్ ఒక్కసారి మాటల దగ్గర కొద్దిగా అది మాంటర్ కొద్దిగా బ్లాక్ సార్ మాంటర్లో ఏదన్నా కొద్దిగా కనపడింది కనిపించింది. ఇందాక సార్ ఏదో పెట్టింది నాకు పిక్చర్ జస్ట్ ఏదో ఒకటి అక్కడ నుండి సార్.
Yeah, it is audible. Yeah, it is audible. Whatever you are speaking is clearly heard here.
Dr. Arvind.
Dr. Sonia.
Yeah. Is it adequate?
Yeah, it is adequate. Good transmission is happening. The transmission
Voice,
is
is it adequate?
Yeah, it is good enough.
Yeah, thank you.
Okay.
Sonia.
Sonia,
can you say your name out loud?
Actually, there is a delay in the transmission.
Okay.
పాస్ అయ్యారని లేబర్ రెస్పాండ్ అవ్వలేదు ఇక్కడ స్టోన్ తీసేసాక మీరు వెళ్ళండి అక్కడే చూడు నువ్వు ఇందాక పోయినావు కదా ఆ బ్లాక్ లోనే చూడు ఆ బ్లాక్ లోనే రైట్ సైడ్
Hello. For
You be here, Jennifer will be there. Okay now. Madam, you
Afu.
Medina అక్కడ ఉంటాడు.
జస్ట్ 1 సెకండ్ సార్
స్టాండ్ బాగాలేదు సురేందర్ ఇది సురేందర్ ఇది స్టాండ్ చూసి
ఇప్పుడు మాట్లాడు
Hello.
స్టాండ్ బాగాలేదు కొంచెం చూసుకో
నా స్టాండ్ పెట్టుకుంటున్నా 1 సెకండ్ కూడా కొంచెం తక్కువ
ఇది నేను ఉంటా కదా నీ స్టాండ్ ఇక్కడ నేనే ఉంటా కదా ఈ స్టాండ్ ఇస్తావు కొంచెం కావాలి
నా స్టాండ్ పెట్టుకుంటారు నాకు అన్న అక్కడ ఉంది తీసుకో ఇప్పుడు ఏం చేసామంటే ఇంకా తలకాయ నొప్పి కంపల్సరీ
ఓకే
లైవ్ అవుతుంది కదా సార్
అంతే
ఎందుకు నాకు స్టాండ్ అది తీసుకురా
Hello.
కొద్దిగా హైట్ ఉంటానన్నా అది కావాలి
మొత్తం క్లోజ్
కవర్లో ఉన్నాయా?
अब बेसी ना कैमरा को ना बेसी
Hello. లైవ్ కంటిన్యూ ఉందా? కనెక్షన్ ఉందా? లైవ్ కనెక్షన్ ఉందా? సార్ వినిపిస్తుందా?
ఒక 2 నిమిషాలు హలో
హలో.
అప్పుడు నీ దగ్గర జాక్ మెయిల్ ఉందా? అది స్పీకర్ ఇచ్చిందా? అదే
హలో. ఓకే. Hello. 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 Am I audible? Hello. Hello. Hello.
జ్ఞానేశ్వరి నా పెన్ను పింక్ కలర్ చెప్పనా
చాలా డిలే ఉంది. ఓకే.
Okay, so poem and EUS&ERCP is here and the remaining is here, huh? We are going there. Are you coming there? The class is going to start.
Half an hour, an hour. You can, you go. You come with after the there.
ఫస్ట్ ERCP తర్వాత EUS పోయం సెకండ్ పోయం అక్కడ ERCP
So how many EUS&ERCP?
like two
EUS&ERCP and one
one poem and another 3 cases of EUS therapeutic EUS.
That's what you're going to do.
Yeah,
That
in
is
this room 5 to 6 cases will be there. In that room 7 cases will be there.
Sir, ఇక్కడ రెండు ERCP
ERCP ఈ రూమే కాదు థెరపీస్ అన్ని ఈ రూమ్ BFMS ఇంటర్వెన్షన్ ఇప్పుడు అదే కేసు షిఫ్ట్ అయ్యేటప్పుడు మీరు ఎక్విప్మెంట్ రెడీ 15 minutes పడుతుంది మీరు షిఫ్ట్ చేసుకుని కొత్త కేసు చేసుకుంటాం 20 minutes పడుతుంది
posted 11 cases. Basically, rollers with how many years we posted?
endoscopy కావాలంటే 750 గ్యాస్
పోయంకి
పోయంకి
కానీ అంతే ఇంకా ఎండోస్కోపీ అక్కడ అంతా ఇచ్చేసి
దీపే అవుట్ తీసుకొని సాఫ్ట్వేర్ ప్రాసెసర్ నుంచి హెచ్డిఎఫ్సి కేబుల్ అంతా కాకపోతే ప్రాసెసర్ నుంచి సాఫ్ట్వేర్ ఇచ్చేసి ఇప్పుడు డిబేట్ హెచ్డిఎఫ్సి కేబుల్ కదా వాళ్ళు అడాప్టర్ కదా అవుట్పుట్ హెచ్డిఎం ఉంటుంది మానిటర్లో హెచ్డిఎం ఎక్కేసి డివి అవుట్పుట్ తీసుకొని సాఫ్ట్వేర్ కల్పిస్తున్నాం సాఫ్ట్వేర్ ప్రాసెసర్ మానిటర్కి రాలేదు కదా. ఇప్పుడు క్యాప్చర్ కార్డులో హెచ్డిఎంఐ అవుతుంది కదా. క్యాప్చర్ కార్డులో హెచ్డిఎంఐ ఉంది కదా. అవుట్ తీసుకొని మా ఇంట్లో హెచ్డిఎంఐ అక్కడేమో స్టాండ్ అదే ట్రైప్యాడ్ ప్రాబ్లం ఉందంటే మళ్ళీ మనకు తెలియదు ట్రైప్యాడ్ ఏంటంటే నాదే పెట్టుకుంటాను.
ఆయన దాని పేరు తీసేసాను. ఆయన దాంట్లో తీసేసాను, నేను తీసుకుంటాను. కంటిన్యూ లైవ్ ఆఫ్
వేరే రూమ్ లేదన్నా ఖాళీ రూమ్ ఉంటుంది నాకు కేబుల్ లేదన్నా
ఏమన్నా చెప్పు, ఏమన్నా చెప్పు, ఆడుకుంటున్నా చెప్పు, ఏం చెప్పు.
ఇక్కడ కూడా ఉంది.
ఎక్కడ రాలేదు నన్ను కేൾకుంటుంది. మీ పని నా పని నాకు నేను యా ఊర్లోకి రాలేదు. బాయ్ బాయ్. ఆడ కేబుల్ ఉంది పో. ప్రసాద్ ఇందిరాలే
నీళ్ళు పెట్టాలి. దానికి ఒకసారి మీరు చెక్ చేశారు కదా.
Impact of What they did is that they went on that as soon as you pass your scope, there are 4 type 1 is the regular, type 2 is a very small papilla where the opening of the orifice is less than 3 mm. Type 3 is the opening of the tubing side, and type 4 is the so this is the macroscopic appearance we want you to get and this is the of the papilla being the type 2. What is the impact of doing this? The impact is that whenever you have type 2, expect the cannulation failure of that is 1 out of 10. If you see this, you may not be able to do anything. Difficult cannulation, 52%. More importantly, complication. If you see type 2 papilla, expect that every 5th patient with type 2 papilla you might end up having pancreas. So the reason why I put up this slide is that as soon as you pass your score, if you are a beginner ERCP, if you notice a type 2 papilla, and if there is no harm in giving call to a senior saying that I may require because this is one papilla which has got a very high failure rate, 50% of differential cannulation and pancreatitis. So for beginners, this is one simple way of understanding what you should do and where you should follow your senior. If that's the macroscopic appearance, other popular is one that we see a lot in our ERCP is the diverticulum. So when you see a diverticulum, there is a common myth that it may pose a challenge to cannulation. So just to understand what the types you can see, this is the simple classification of the diverticulum where they say that the diverticular can, the papilla can be on the rim of the diverticulum or it can be within it, either intradiverticular or extradiverticular. So I think the word intradiverticular makes it very clear that the papilla is right in the diverticulum. Now where exactly the diverticulum? It can be either at the bottom of the divert or on either of the peripheries, that is DND, or right in the center of the divert, that is considered as A. So this is probably the most common type that you see, and of these intradiverticular, 1C is what I want you to remember. This is the next slide I think. So if it is on the border of the divert, well, it can be either on the left or right of it, or it can be in the center of what we call as the pendulum, or it can be type 3 that is very far away from the what the typical impact of having these diverticulum? These are the position change. You have a diverticulum and you should see and surprisingly, contrary to belief that papilla divert challenge what my seniors to point out that the most of the literature suggests that one where the divert is on the floor of the abdomen before the divert there, you find a challenge in cannulation. They say that the rest, the cannulation success and failure is just like a data. This is about knowing, but what I want you to understand is that there is an increased risk of bleeding when you are having patients with and of course, for people who have just started ERCP, we should understand bleeding. Guided the doctor, we all know that the papilla is supplied by a rich artery of arterial supply coming from gastrointestinal and it's the pancreatic and pancreatic. This is a very good study which is not only where they did is that they did a postmortem, they got the ampulla nearly 20 patients and they did electron microscope dissection. This is the big clots in the ampulla per se, and what you are seeing around the dial are the clots of various
The patient is in left lateral. I gently try to pass the scope over the patient's dorsum of the tongue and then I think patient needs a little. So once try to pass the scope till you reach the G junction. So the moment I reach the G junction, I tend to open up my left hand. So I make my left hand parallel to the patient bed. So as you do this, on the left side of the screen, if you are seeing it there, is usually the fundus, and somewhere between 3 to 6 o'clock is the distal body of the stomach and the antrum. So what I try to do is that I just start pushing my scope more towards that side, that is 10 to 3 to 4, 6 o'clock. Yeah, there is some amount of fluid here, bilious fluid. So we are taking it out and then inflate gently, try to understand and then proceed till you see the pylorus, and as sir was telling, you should look for the sunset sign. That is, try to understand where is the pylorus, which you can see is here, and then you enter the D1. So by the time I enter the D1, usually my scope from being parallel to the patient bed is exactly 90 degrees. So from here, I turn slightly clockwise, trying to understand where is the D2, and then gently entering the D2. So there you can see me slightly pushing the scope into the second part of the duodenum. And I try to make sure that I have passed well beyond the ampulla, and if that's the case, I'm expecting seeing some slight narrowing here, but we were able to slowly enter. So as history was given that this patient already underwent couple of ERCPs. So we have a stunt in C2. Sir, what's the approach, sir? Your approach, you take a snare or a foreign body force?
We will take a snare.
So because snare makes it easy for me to pull out the stunt from the scope, not removing the scope. Yeah. So what I'm going to do is that I'm going to pass it. Since it's a 8 French stunt, it should come out through the scope. Yeah. Open. And gently try to maneuver your open. Yeah, open. Right. Okay. Closely. So this is what big snare, 3 centimeter snare. Okay. Yeah. Open now. Yeah. So since we are having it's not opening, we'll try to go as suggested in between and see if we can open it. Open. Open. Yes, sir. No, but yeah, I'll try to take it from the scope, sir. Catch. Huh? Yeah. So the idea is to take it out through the scope. So this way, you don't need to take out the entire scope. So I think some. So since this case was attempted already, yeah.
Something come out.
Yeah. So as you can see, 2 attempts of ERCP was made. So our plan is to cannulate and do probably CRE and then attempt all over again. So I think for beginners out there, this is the position, sir. I mean, we want the ampulla somewhere at 11 o'clock. And if you're attempting a CBD cannulation, we go below, the scope is below. You come from below upwards and the small wheel is more towards the right. Whereas if I'm attempting a PD cannulation, I try to keep the scope on par with the ampulla and go slightly left. So I think that's how I try to do the selective cannulation. So here, since it is CBD, so I go below the papilla and then gently engage from below upwards. And since sphincterotomy, everything was done, I think cannulation is not a challenging issue. So once we are in, we'll get the fluoro on. Contrast. Yes, sir.
Are you comfortable?
No, sir. I'm going to turn a little bit. Yeah. So we get the fluoro view going. I think we are into the CBD. So we are going to use some little bit of contrast to understand where is the stone person. Wait, don't do. Yeah, good. But little bit sank. Yeah. Yeah, I think we are selected to the left hand. So what we do now is that, come, yeah, good enough. So we can lock it here and we'll try to give some contrast. See where we are actually, yeah. Contrast please. Contrast. So we are able to visualize a big stone here. Contrast, yeah. But CBD is dilated, sir, but I think the stone is right down there, sir, below the scope. Below the scope. Below the arc of the scope.
Yeah.
There's a stone, this looks a little bit considerably inflated. Yes, sir. Maybe that's the reason they're having challenge.
Yes.
Yeah. So the idea is,
Sir, you have done well above the sphincter, real sphincter.
yes, sir.
Actually, if you started here,
Sir,
it would have been a better way because you don't have adequate
space now. Yes, sir.
But anyhow, you can attempt towards sphincteroplasty.
Yes, sir. So the as suggested by Shankar Sharma sir, we are going to do
one
it.
thing, you
Yes,
said
sir.
you pass a balloon, clear down the distal CBD first.
Sir, I think it
You will
is.
get something which
Sir.
will help you to clear the passage.
But sir, I feel the stone is already in the distal CBD.
There.
Yes, sir. Yes, sir. Balloon.
Balloon.
So ideally, if a ERCP is done already and the stone there was a failure to remove, so usually my second attempt either I bring in the lithotripsir or probably a spine. Spine cholangio is something that we do more often at our place.
With the laser.
Yes, sir. Laser, EHL, we have both, so we are at a luxury if there is a first time failure.
Now with eyeglass, what do you attempt?
We attempt either, we have both facilities, sir. We have the laser and the
You are
EHL.
doing EHL which you will pulverize it into powder.
Yes, sir.
No need for spike.
Yes, sir.
You can as well use the routine balloon.
Yes, sir. Traction. As I was mentioning the talk, sir, I think technician also matters. We also should be
Video brings his own
traction.
Many foreign doctors are also
Yeah.
bringing
Yes, sir.
technicians.
Fluoro? I think we are well above it, sir.
Yeah.
Inflate, 1.5 cc. Fluoro? I think we are to the stone, sir. And the balloon is out. Balloon is not functioning. Yes, sir. No, I think it is.
Old balloon.
Yeah, probably.
Oh, sir.
Yes, balloon is ruptured. The balloon is probably already, you can see it's ruptured. So we didn't see much inflation there also.
Right, leaking.
Okay, no problem. So I think we'll go straight away with CRE, sir. Yeah. Fire in. Yeah. So, no, actually balloon was well much below. I didn't even feel the resistance. Balloon just gave us. So we'll go with CRE.
Yeah, some spike of the stone would have bitten the balloon.
Yes.
Using it as an anything.
Possible.
So you better go with CRE.
Yes, sir.
Yeah.
So here the unique challenge is that the stone is well below. So our CRE balloon traditionally are 5.5 centimeter. 12, 13, 15. So what I do is that, sir, what you do, sir, because your stone is well below, you feel that the stone might get impacted with the CRE balloon, because these are very long balloons.
Slightly, some chance is there,
Yes, sir.
but
Demon. Please take out the light.
already prayer microplastic is done.
Yes, sir.
So you know how much you have to send inside the vein.
Absolutely. Yes.
You can keep it out also. Little bit
Yes.
more. More of the balloon outside and little
Agreed, sir.
inside.
Yes, sir.
Probably we
So
should.
I think that's a nice trick to make sure that the stone doesn't get crushed or pushed into the CBD.
But anyway, it goes into proximal CBD even if it is put the
Yes.
little bit high. Proximal CBD no problem. Because
Right,
the
sir.
adequacy of the distal CBD that is more important for the retrieval of the
Yes, sir.
after spindroplasty.
Traction,
How do you
traction.
feel about the distal CBD after this?
Sir, after giving contrast, I thought distance if there is no stricture, sir. It's looking okay. Yeah, I think as Shankar Sharma sir was saying, we'll keep most of the balloon outside and then we'll inflate. Inflation done. So we are going to do a 12, 13 and 15 CRE dilatation depending. Yeah, graded dilatation.
One go.
No sir, graded we'll do, sir. We'll do 12 first and then depending on the situation we'll escalate. 12.
One minute.
30 seconds, sir. Yeah, sir. So there's a recent paper, sir, where they have shown that 30 second, 1 and 2 minutes they have tried and they found that 30 is as good as 1
So
minute.
anybody kept time?
12. Sir, I'm seeing there, sir. So 11, 35 is 30 we started, it is 37. Yeah, 35, 40.
So it should come to 65.
60, sir. 35, 60 or 36 we have done.
That one.
Yeah, seconds.
48, yeah,
Yeah.
50.
So we have done 12, I think, sir. Yes. So we'll deflate and again we'll inflate. Deflate.
ఇందాక తెచ్చింది కదా కొత్తది
It looks good. Okay, go ahead.
తెచ్చింది
Go.
నాలుగైపోయింది
Inflate. Now inflate.
Down.
Now we'll go to 13.5, sir. So as you suggested, graded we'll go. So let pain because of CRE.
13.5.
So again 35, sir. We started 35 seconds. So I'll count it for another 30 seconds to come back. Stop. So we are doing a 30-second CRE dilatation. Now this time you inflate go to 15. Go to 15.
Doctor? Okay, very good. See the time.
15 seconds, sir. So,
Start at 15.
yes. Lock it. Yeah. So what was the worst complication you had, sir, after CRE?
Only little bit bleeds.
Okay. I think contrary to
We
the
have not encountered any complications.
yeah, the corporation, yeah, I think that's the next common rather than perforation. I think we have done the maximum, sir. So usually once I've done a CRE, I will check whether there is any bleeding. Sir, what do you do if you have a bleed, sir? What's your
No, there's a few RBCs you can ignore.
So usually what I do is that sir, I reinflate the balloon to a lower number and just keep it for 3 to 5 seconds. Yeah, not to the same 12, but just 10 or 8 and then just leave it for 2 minutes. Usually take a minute. So yes, the idea is to use the basket. Now is it wire guided? Wire guided? Wire guided? No, the basket you are using is wire guided or independent? Yeah. No, if you are giving a wire guided, I keep the wire. If it's independent, no wire required. So we are going to use the basket.
But try balloon. You can come out with a balloon itself.
Sir, already we lost a balloon.
No wire. Balloons are there.
Basket? Yeah, they are wanting immediately. Okay, open it, no? Open the basket. Open the basket. Close. Why also? Because we have such a good dilatation, I can really see the CBD straight away. I think we can do without also. I can gently, easily pass the. Yeah, I can already see the CBD here. So we are trying to enter the CBD. Yes. Fluoro. Fluoro. Yeah, I think we are in. Yeah, open. Wait. Let me go up. Fluoro.
Now you open.
Open. So we are going to do a dry run, sir, just to see if we have fluoro. We are out. So we need to go little. I think the CRE has pushed the stone slightly up, sir. Fluoro. See, the stone is here. It's hitting the stone.
Just above the scope, behind the scope it is. It is hiding behind the scope.
Now open. Open up.
Outside she opened.
Yes, sir.
Sometimes she feels shy to open in the dark.
Yes, sir. Fluoro? Now it, I think. Yeah, it's open now. Yeah, now. Yeah. Okay. I think there is a.
Gone?
Yeah, I think they lost the handle there. Slowly, careful.
Ordinary accessories.
So I think we are going to change, but I think the stone is big, sir. It's right above the cystic duct on the top of the screen.
Yeah.
Concho, can you push the fluoro?
Almost going nearer to the hilum.
Yes.
Yes, it is near the hilum.
Yeah. Fluoro? Yeah, I think now you can see it very clearly, sir. The stone is above the cystic duct. Let's see if we can push it. Right. Now you push. No, you are going towards the cystic duct. Wait, don't open.
Do one thing.
No, don't open. Because you haven't. See, stone is very above. Don't open below.
You can't open the. You do one thing.
Fluoro?
You go for a balloon crawl, bring it down little bit.
Yes, sir. That's
Not
why
be able to get it out.
or we can.
Pull it down up to the distal CBD.
Yes.
Then it will be easy for you to
Yes,
catch it.
that's one option. Or wire guided. This is wire guided? No.
No, you have to bring it down.
No, sir. If this is wire guided, we can pass this above and also engage the stone. But since this is not wire guided, we are going to take a regular balloon.
So you take a balloon and crawl it down.
Balloon and guide wire. But stone on floor appears to be big, sir.
Yeah, very big.
Yeah.
When this
Hence-
spectroscopy and
Yeah, sir.
this is not enough. You have to
Yeah,
go
yeah.
for mechanical
Yes, sir. I think ideally mechanical or spike or angio would probably make it easy. Yeah.
But the surgeon, why they would not do it?
Yes, sir.
Really
Yeah.
ambushed.
Yeah. This being open coli, sir, not even lab coli. Yeah. They should have probably engaged it. Quiet, please.
No, it's actually on opening, if they have seen gangrene and necrosis, the surgeon will get
Quiet, please.
in that situation, they will get confused. Even cystic gut, common hepatic gut, all these things are same. They look.
No, I think wire is, yeah. Wait, what?
I got wide.
No, it got quiet, yeah. Yes, now try. No, wait, you are going towards the stick. Yeah. Try now.
Again, it's going to stick.
Arvind sir.
No, you are going
Arvind,
back. You
Arvind,
need
sir.
to go.
Arvind sir.
So we need to selectively engage above the stone before we can pull this down. Go? No, same thing is there. Yeah. Yes, go. Yeah.
Yes.
So we need to climb up, wire up, yeah. Yes. Inflate the balloon. Inflate it. So as Shankar Sharma sir was saying, we'll pull the stone slightly down and see if we can throw. Slip in. I think the stone is still up, but we'll do the balloon trawl anyway.
No, stone has come down.
No, sir. Stone I think is still in. Let's see.
The stone academy.
So I think, can you do a fluoro? I think we have pulled it down, sir. It has come down. Yeah. Above CPD is clean.
So you are coming with a balloon.
Yes, sir. I reached. I think the stone has come here. You can probably see the stone there, sir.
Yes.
We can already see. We might end up sacrificing the things here. Yes, sir. So we are going to do a little jiggle and let's see if we can pull this out. Fluoro? I think stone is pretty much down.
Push it down.
Inflate? Balloon has come. Did we end up sacrificing this? Is the question. No, the balloon survived. Balloon survived the assault. No, I think sir, one option is putting a basket. So you can see the stone already out there.
Now it has come.
So
It has come. With some saline water
inflate.
will come. Saline water will facilitate about the fragment.
Yes. So
Saline water.
you think 1.5 or 2 cc? 2 cc. Inflate to 2 cc. No, inflate. Balloon inflate up to 2 cc. 2 cc? Yes. 2 cc, yeah? So we got a fragment out. Yeah. Let's see if we have anything else left. Sir. 2 cc, yeah? Deflate. Fluoro?
Yeah, make another
inflate.
trawl.
Yeah, 2 cc inflation. 2 cc?
Yes.
Yeah. Fluoro? I think, yeah. Coming down.
Are you feeling any resistance?
There is a resistance, sir. Maybe a fragment is there. Yes, sir.
I think you will bring it out now.
Yes.
Yeah, it is coming out.
So we are going to gently push the scope into the third part of the duodenum, sir. I think deflate. I think there's a stone left there, sir. Yeah.
Yeah, you give saline, it will come down.
Yes, sir.
Saline wash, I think we can use. Some more saline wash.
No?
No, don't push it out. Wow.
Yeah. I think one more try before we think that's good enough. Yeah. Inflate. 2.
Go up.
I think we are quite up, sir. Yeah.
Where?
Cystic duct. Now coming down.
Push it down hard.
Yes, sir.
No problem.
I think the balloon, in spite of using 2, I think slipping. You can see the stone there, sir. Maybe we can try a basket now.
Yeah, yes. If it opens where?
Wire gated basket? No? Yeah. Regular.
Because it is radio height.
Okay.
Basket. Balloon has not ruptured.
No, sir. Balloon is intact.
Oh, it is quite fast.
Basket. Okay. So we are going to now, we have tried the next level. We have tried the balloon. We had a partial success with the trawl balloon. Now you can see a stone impacted there in the distal CBD. So the idea is to pass a basket above it and try to extract it. Let's see. Yeah. Toro, I think our basket has gone in. Wait a second. Yeah.
Yeah, you open it.
Open. Full open. Yeah, I think we are fully open if fluoro is there. Now what I'll do is that I'll keep the basket open and I'll try to jiggle in. Try to engage the stone. Fluoro. Hopefully, yeah, keep it like that only. Tighten it slightly, not full. Yeah, fluoro. Yeah, sir, we have engaged it, but it's caught there.
It is caught.
Now
Yes,
don't
coming
crush
out,
it.
take the
Don't crush
photo.
it. Sohendra, we have a Sohendra standard. Sohendra. I think we are done. I think it's done.
Fantastic. Now clean the scope. This one.
Yeah, sir. So I think one quick sweep with the balloon and we are done. So I think the trick, as Shankar Sharma sir was saying, is that pushing the scope down. I think that will give you enough traction to pull out the stone. Wire back. So I think we are done. I think the stone is got. This lady will get a lot of relief. So I think
has come out.
Yes.
You have
Sir,
done successfully.
yeah, sir. Do you want to really stunt it again, sir? I probably, because lab call is done, I might not do it. What's your opinion, sir?
No, already cholecystectomy is
Yeah,
done,
yes,
right?
sir.
Sphincterotomy is
Yes, sir.
sphincterotomy.
Yes, sir.
And you can just go into the price tag by
Yeah,
yourself.
Fluoro? Yeah, I think we are very much in. 2 cc sweep and then we are out. Fluoro? Yeah. Inflate 2 cc?
Not necessary for any,
Yes, sir. Agreed, sir.
but we create some unnecessary problem.
One more procedure for the poor lady.
Sometimes they forget to come back for follow-up.
Yes, sir. So 2 cc came out completely, sir.
You have done extremely well. Thank
Sure.
you.
Thank you.
Congratulations.
I think, sir,
Only an expert like Rakesh Adi can do this. Miracle gear.
I think
Twice failure, even surgeon's failure. And bile duct was slender actually
sir.
because already it was excised bile duct. So some fibrosis would have settled in and very difficult.
So I think one tip for the beginner friends, so whenever I do this complicated procedure, first I come out, I try to suck out the air because we are not using CO2, and then I do a check fluoro, sir, just to see the perinephric
All the
air.
fluid you have to suck out.
Fluoro near the kidney, yeah? Kidney. Any perinephric air I just see, that's not there.
No.
And I try to check this, sir.
Yeah, checklist. Anybody in the world, checklist is more important.
Thank you, sir.
You have done extremely well.
Thanks, sir.
Your repertoire excellent. Next poem. You want to breathe for a while?
Office.
Pranayama? Coffee. Coffee.
You are accessible, you should be there. Two ladies she is using for spine. She just gave people you are accessible, you have to be there. Sir, coming sir.
Have coffee.
Yes sir. అదే కదా హరీష్ ఏమంటారు యువర్ యాక్సెసిబిలిటీ యు ఆర్ సపోజ్ టు బి దేర్ ఊరికే టుక్ మాట్లాడు యు లూజ్ థాంక్స్
పోయం ఉంది నెక్స్ట్ పోయం తర్వాత యూఎస్ సిడిఎస్ రెండు మైకులు మీరు ఒకటి తీసుకోండి.
ఇంకోటి ఇంకోట ఇప్పుడు ఆపరేషన్ ఎదురున్నాయి ఇక్కడ వాళ్ళ ఇంటి పెడతావు నేను ఆడ క్లోజ్ చేద్దా సార్ లైవ్ ఉంది సార్ లైవ్ కంటిన్యూ అవుతుంది అవును
షిఫ్ట్ చేయడం ఎంత ఉంటుంది?
వద్దు తీసుకొస్తాను ఎందుకు ఒకసారి క్లోజ్ చేస్తే అయిపోలా మళ్ళీ ఆన్ చేసుకుంటే అయిపోతుంది కదా
Sir?